Let's dive into how to read a CBC. So if you look at the CBC have WBCs, RBC, hemoglobin, hematocrit, MCV, MCHC, RDW, platelet, then lymphocyte, monocyte, eosinophil, then percentage of neutrophil, lymphocyte, eosinophil, and basophil. So the first thing mostly I would look at the WBCs, then hemoglobin, then hematocrit, then MCV, then platelet count, then neutrophil and lymphocyte count. So these are the top things that I mostly see in the CBC. And lymphocyte mostly increase in viral infection, neutrophil mostly increase in bacterial infection if patient have an infection, right? But the first thing we see is like the major basic stuff. Right. Let's talk about how to read CBC. So every time as an intern or resident you will see the CBC in the morning. So you need to understand and kind of having an idea how things going up and down. So let's start from looking at the hemoglobin. This is very, very important, right? So the first thing we see is the hemoglobin, right? So the normal hemoglobin is like kind of between 11 to 16, right, in both male and female. Less than 11 is kind of anemia. More than 16 could be because of some physiological response, some pathological response you will see. And so after seeing the hemoglobin, there is one more important stuff, which is kind of the RBC, right? So the RBC count, the normal is like from 3.6 to 5.5. That's a normal RBC count. 5.5, like both in male and female, is roughly estimate. And then, so let's talk about what are the things that can increase the RBC, right? So the first thing, so as an intern and resident, the first thing you always have to rule out what are the acute causes, like more apparent cause of increased RBC. So the first would be like a dehydration, right? If patient is dehydration, then because of the concentration, your RBC could be high, right? So that's the first thing. And the other thing I will look at, if patient have like any cause of chronic hypoxia, like a COPD, obstructive sleep apnea, high altitude. So among those patient, RBC could be high. And then I would kind of, if I exclude all of these things, then I would kind of, looking at if there's any cause of, the cancer or something, right? Sometimes polycythemia vera can increase the RBC count. And erythropoietin secreting tumor can increase the renal cell carcinoma, like hepatocellular carcinoma. Those kind of cancer release erythropoietin, which increases the RBC synthesis, right? So that's the things that can increase the RBC. Let's talk about like what are the things that can decrease the RBC counts. Okay, so the things that decrease the RBC, of course, anemia, blood loss anemia, acute or chronic. Then some vitamin deficiency like iron deficiency, vitamin B12, folate. If patient have like any sickle cell disease, G6PD, bone marrow failure like aplastic anemia, chemoradiation. If patient have chronic inflammation or something like that, right? So that's how we look at the RBC count. Then let's talk about the WBCs. So the WBCs normal count is like from 4 to 12 roughly, but sometimes you can see like 3 to 11, 3 to 13 sometimes, okay, right? So the first thing, if the WBCs are high, right? So what are the things that can increase the WBCs? So as an intern, when I was in rotation first week, I had a patient who have a WBC of 15. Then I tell the attending, oh, this patient's WBCs are high, this patient could have a fever or infection. Then he told me like patient is on steroid, which can increase the WBC, right? So the first thing you have to rule out what are the common things that can increase the WBC count, right? So the first one is like if patient is on steroid, right? So you have to think if patient have like a COPD, or anything that patients may be on a steroid. If patient on a steroid, then high WBC is fine, right? It's not that a problem. Then stress sometimes can increase it, and also smoking can increase it. And then you have to think about infection, inflammation, and the last you can think about the more severe, like a cancer, leukemia, and myeloproliferative diseases. If patient have high WBC, if patient's not on a steroid, not in stress or smoking, then you can go back and see what is the baseline, like what's the normal WBC patients like last couple of years. Then you can make a idea, okay, this patient's baseline is a 10 and now it's a 16. Then you think, oh, a patient have a fever, right? So what's the definition of fever? So definition of fever is like 100 above 100.4. That's the definition of the fever. If patient have high WBC fever, then you go and check like the infection marker. Maybe you can order lactic acid, CRP. Also you can so these are the things that we can do. Maybe you can do a chest x-ray if patient have any cough, or urine culture, blood culture if patient have some relevant information, then you can see it. And let's talk about if patients have a WBC is kind of low, less than 4, right? So what would you think about? So mostly we always go from what are the common things that can decrease, like a viral infection, if patient have like any sepsis, if patient on any drug like a clozapine, carbamazepine, methimazole, all those drugs can decrease the WBCs. And if patient have any bone marrow suppression like a chemo, radiation, aplastic anemia, you kind of think all those things, right? If patient have anything like a chronic, then you won't do anything, right? Okay, so that was about WBC. Let's talk about the platelet, right? So how about the platelet? So increased platelet could be because of a reaction, like maybe infections, like inflammation. If patient is coming from surgery, iron deficiency, all those things can increase the platelet. And then you go higher if patient have like any myeloproliferative disorder. So always try to think like the common stuff, like a infection, inflammation, if patient had surgery, iron deficiency. And then you would think about if patient has a low platelet, right? So normal platelet is like from 100 to 250. Always like above one lakh we don't consider if patient have like a severe or something like that. If patient have less than 1 lakh, then we think about, right? So if patient have less than 1 lakh, then you would think, okay, always go for the usual causes. If patient is on any drug, any chemo, patient have aplastic anemia, or patient have any autoimmune or drug induced, if patient on heparin, if patient have sepsis, DIC, splenomegaly, then you kind of think more on if patient have like any cancer or something like that, right? So that would be the platelet. And then if patient have the low hemoglobin, the first thing we see is MCV. If patient MCV is so normal MCV is from 80 to 100. If patient have less than 80, it means microcytic anemia, right? So the microcytic anemia causes like a hemoglobin. Focus on hemoglobin word, right? So the hemoglobin is made up of two stuff, like the heme and the globulin, right? So the globulin means the protein, so which means like the alpha thalassemia, beta thalassemia. Those thalassemia can cause iron deficiency, like the microcytic anemia. And then heme is kind of made up of two things, right? The iron itself and the protoporphyrin, right? So iron deficiency anemia can cause the microcytic anemia, and protoporphyrin, right? So that's a protein. So to combine iron, protoporphyrin, you have to have like vitamin B6. So vitamin B6 deficiency can cause it, and also the lead poisoning can cause the microcytic anemia, right? So these are the causes of microcytic anemia. And then if patient have a MCV of more than 100, which means a megaloblastic anemia. So the common reasons are vitamin B12 deficiency, iron deficiency, alcohol, liver disease. And if patient has like in between 80 to 100, which means a normocytic anemia. So normocytic anemia is we mostly divide into like the extravascular hemolysis and intravascular hemolysis, right? So it means patient have something like a hemolysis going on. That could be because of the G6PD, because of some drug induce, maybe because a patient have mechanical wall, or a patient have like a gluten like a warm and cold, like autoimmune anemia, hemolytic anemia. Those can cause anemia as well. And then sometimes we can see the MCHC score. If MCHC score is high, then it could be because of hereditary spherocytosis. Sometimes autoimmune can cause, and if it is decreased, iron deficiency and thalassemia can explain it. Eosinophil mostly increase in like allergy, asthma, parasitic infection, sometimes in Hodgkin lymphoma. Decrease could be because of the steroid. So remember, steroid increase the WBC, decrease the eosinophil. And also in Cushing syndrome, you will see the less eosinophil because of the high steroid. Basophil, whenever you see high basophil, most of the time could be concerning because it can be because of CML, but sometimes it can be associated with the hypothyroidism. And yeah, so these are the major stuff mostly we see when we read the CBC. That's the first example of CBC. WBCs are normal, RBCs are okay. Hemoglobin is 9.5, which is anemia. And then the next step I would say is MCV. The normal MCV is 80 to 100. This patient is 65. So this patient has the microcytic anemia. Then you will think about the reasons. That's another example. Hemoglobin is 10.2, which is anemia, and MCV is more than 100. Patient have a megaloblastic anemia. Then you look for B12 deficiency, 9, liver disease, alcoholics. Then we have WBCs are high, eosinophil is low. So this means most likely this patient would be on a steroid, right? So double check if patient is on a steroid. If patient on a steroid, that's okay. If not, then see the temperature, any sign of infection, and then go from there.